This PowerPoint will cover Chapter 12, the portion on anatomy and physiology. The respiratory system is divided into two portions, upper and lower. The upper respiratory system is considered to be the portion above the thoracic cavity, and the lower respiratory system is the portion that is within the thoracic cavity. The respiratory system, together with cardiovascular and hematologic systems, have one goal, and that is to deliver oxygen to your tissues. The oxygen is taken in by the lungs and diffused into the blood in the respiratory system. That's one part. The second part, hemoglobin in the hematologic system carries the oxygen in the blood. The third part, the cardiovascular system, with its arteries, transports blood to the tissues where it perfuses into the tissues, and the tissues get their oxygen and then bring the carbon dioxide waste products back. Disruption in any one of these three systems makes the other two have to work harder to compensate to keep oxygen delivery at an optimal level. When you have disease in any one of these three systems, it makes it more difficult for that particular system to compensate during stress, which makes the other systems have to work even harder. Let's start out by looking at the upper respiratory system. We'll look at its structures and the functions of each of these structures. The basic functions of the upper respiratory system include air movement, airway protection, and speech production. There is a good picture of the upper airway structures in your book, and we will also look at pictures of these structures on the following slides. As you can see in the picture, there are a lot of small structures very, very close together that make up the upper respiratory tract. This tract is actually just a passageway, and it moves air from the mouth and the nose through the pharynx, the larynx, and into the trachea and the lungs. It also can move food from the mouth into the esophagus, and that can cause some problems, as we'll see a little bit later. So part of what you see here are very, very specialized structures. For instance, one of them is the nasal cavities. Those are lined with mucous membranes, and they have little cilia in them to propel mucus toward the larynx for swallowing and expectorating. You have the epiglottis, which assists with swallowing, that we'll see later, vocal cords, which have to do with speech, and then you'll notice your esophagus and your trachea are just right next to each other. Your pharynx is posterior to the oral and nasal cavities. The upper portion of it is called the oropharynx, which is closer to the mouth, and the other portion of it is called the nasopharynx, which is that closer to the nose. You also have your soft palate there, which you'll recall from assessment class that you look at when you look up to the top of the mouth, and then there's your uvula way in the back, which will rise to block the nasopharynx during swallowing. There's also, when you go a little lower, an epiglottis. The epiglottis acts like a hinged door, and what happens here is when you swallow, your epiglottis closes over the larynx to prevent the aspiration of food and secretions into the lungs. If your swallowing reflex is weak or absent for any reason, then that increases your risk for aspiration. So an example of this is when someone has had a stroke and that has affected the innervation to their swallowing reflex, and so their risk for aspiration is greater. The nasopharynx is posterior to the oral and nasal cavities, and this is where your eustachian tubes open. And It's interesting to think about everything that's related here, and it's in such a small space and it all drains in. And so when you're very small, like when you're a baby or a small child, this area is even smaller. And so if you have an upper respiratory infection, a cold, something like that, your mucous membranes are swollen, it blocks off the opening to those eustachian tubes, and that's where you get pressure in your middle ear, and you'll get often otitis media. Your oropharynx is between the soft palate and the base of the tongue in the back of your mouth. You also have lingual tonsils there at the base of the tongue, your adenoids, which is also called a pharyngeal tonsil, and then the palatine tonsils, which are that ring of lymphatic tissue that we taught you to look for in physical assessment. These tonsils and adenoids are lymphatic tissues, and they're very important because if you think about the number of microorganisms that enter through your mouth and nose, having lymphatic tissues there as your first line of defense is very important. There are times when the tonsils and adenoids have to be removed, but for the most part, it's best to leave that lymphatic tissue there, as it is a really good defense for your body against infection. Your larynx is in the area between your pharynx and your trachea. It is formed by 9 pieces of cartilage that are bound together, and they're also bound to the adjacent structures to keep the larynx open, to keep it from collapsing. The thyroid cartilage is the largest, the one that's the most prominent, and we often call that the Adam's apple. The epiglottis is the uppermost piece of cartilage. Talked about that being like a hinged door, and it closes over the larynx to direct food and liquid into the esophagus and keep them out of the lungs to prevent aspiration. Your vocal cords are there as well. They are mucous membranes. They're attached to the front and the back of larynx. The mucous membranes form 2 folds, and then there's a triangular opening in between these folds or vocal cords, and this is called the glottis. And when you exhale air from your lungs, it exits through the larynx and causes a rapid opening and closing, a vibration of the glottis. And then when you make movements with your mouth, lips, jaws, and tongues, that converts the sound made by this rush of air into recognizable sounds of speech. Your paranasal sinuses are cavities that empty into your nasopharynx and release mucus. They're lined with mucous membranes with little cilia, and the cilia beat the mucus down toward the opening, and then those openings let the mucus drain into the nasopharynx. These are big cavities full of air, and they lessen the weight of the skull. They also provide resonance for your voice. So think about when you have a cold and your sinuses are stopped up, sometimes your voice will sound a little different because the airspace is different in your sinuses, and that changes the way your speech sounds. Your paranasal sinuses are cavities that open and drain into the nasopharynx and release mucus. They are lined with mucous membranes, and the little cilia that's in them beats the mucus down toward those openings, and then it drains into the nasopharynx and can either drip down the back of your throat as postnasal drip, or you blow it out your nose. These cavities are filled with air, and that helps to lessen the weight of your skull. It also provides resonance for your voice. So if you think sometimes if you have a cold and your sinuses are full, how your voice changes, and that's the reason why, because the amount of air in those sinuses provides resonance and changes the way your voice sounds. Let's talk about some of the tissues that these structures are made of. So your nose and nasal cavities are bone and cartilage. They're covered with muscle and they're lined with epithelium, and these provide protection. You have nasal hairs in the turbinates in your nose, and those trap dust and microorganisms that you inhale, and they block the entry into your nasal passages. Your nose is separated at the midline by septum, which is bone and cartilage, and we talked about that in your assessment class. Your nasal mucosa is a highly vascular ciliated epithelium. It moistens and warms the air that you inhale. There are goblet cells there that produce mucus, and they trap the dust and microorganisms that you inhale. Then there are cilia, which are those little hair-like structures, and they sweep the trapped particles back into the pharynx, and they can either be swallowed or coughed out. So when you get irritants like trapped particles and microorganisms that are in the mucus, there are receptors in your nose and in your airways, and these trigger either a sneeze or a cough to remove the debris. Another kind of structure that's actually in the lower respiratory system, but I'll go ahead and talk about it here, is your alveolar macrophage. So these are white cells that phagocytize foreign particles and bacteria and provide protection in your lower respiratory system. The trachea descends from the larynx down to the carina. The carina is where the bronchi branch off from the trachea. It is in front of the esophagus, and it's a rigid tube that's about 4 to 5 inches long and about 1 inch wide. It's made of C-shaped rings of cartilage. The open part of the C is posterior, and that's toward the esophagus, and so what faces front is the curved part of the C. The cartilage of the trachea is lined with ciliated epithelium, just like most of your respiratory structures are, and as in the upper respiratory system, the cilia sweep trapped particles up toward the pharynx. The bronchial tree, as I mentioned in the previous slide, branches at the carina into the 2 primary bronchi, the right and the left. The right bronchus is wider and more vertical than the left bronchus, so it is the most likely location for aspiration. Aspiration pneumonia is usually in your right lung for that reason. The bronchi are made of cartilage, as is the trachea, and the cartilage serves to keep the bronchi open and patent. So after the bronchi enter the lungs, they branch into smaller secondary bronchi. There's one for each lobe. The right has 3 lobes, so there are 3 right secondary bronchi, and the left lobe has 2 lungs, and so there are 2 left secondary bronchi. As they go deeper and deeper, they branch into tertiary bronchi, and at this point, they become smooth muscle. They lose their cartilage, and the walls are smooth muscle. The bronchioles are the last division of the bronchial tree, and they also have no cartilage to maintain patency. The lungs fill the thoracic cavity from the clavicles to the diaphragm. The top of the lungs is called the apex, and it's about 1/2 inch above the first rib. The bottom of the lungs, called the base, rests on the diaphragm. The right lung is shorter, broader, and larger than the left lung, and it has 3 lobes. About 55% of the total gas exchange occurs in the right lung. The left lung takes up only 2 lobes because the heart is on that side of the chest, and so it takes up some space. The hilus is in the middle of the lungs where the pulmonary vasculature enters, and the area between the lungs is known as the mediastinum. The lungs are protected by the ribs, and they are covered by pleural membranes. There is one membrane that adheres to the lung tissue, and there's another membrane that surrounds the lungs, and between these membranes is a thin layer of pleural fluid. This pleural fluid provides lubrication and reduces the friction when the lungs expand and contract in the movement of breathing. You will notice that all the structures I've talked about before this slide, I've said nothing about gas exchange, just about the movement of air. There's a term that's known as dead space, and that is the area of the respiratory tract where no gas exchange takes place. That is the mouth, the nose, the pharynx, the trachea, the bronchi, and the bronchioles. That's a lot of space where no air exchange takes place. Normal dead space is probably about 150 cc's. I don't think you need to know that, but that becomes important when you have diseased lungs because you can only get so much air in your lungs, and if most of the air exists where there's dead space and not down in the few little functioning alveoli that are left, that's a problem because there's less air available for gas exchange, and we can talk about that later when we talk about different kinds of lung disease. The bronchioles terminate in alveolar ducts. They divide into little, almost look like bunches of grapes, little sacs. The alveolar sacs are the primary structures for gas exchange. So what you've got in this picture is a terminal bronchiole that divides itself into alveolar ducts, and the ducts are made up of little alveoli. The alveolar sacs are groups of alveoli, and they are surrounded by a network of capillaries. Their walls are single-celled squamous epithelium in order to permit gas exchange. They are lined with tissue fluid that is essential for the diffusion of oxygen and carbon dioxide. They secrete surfactant, which is a substance that you may recognize as being what keeps a soap bubble open, what keeps a soap bubble a bubble. And what that does is it decreases the surface tension so that the alveoli can inflate. There's connective tissue between each alveolus and its neighbor, and that stretches during inhalation so that they can fill with air, and it recoils during exhalation. It's very elastic. Connective tissue is elastic, and when it stretches, it recoils passively. It actively stretches with inhalation and passively recoils, and that makes exhalation a passive activity. That becomes important when we think about the work of breathing in some of the disease states we'll be talking about. As I mentioned, they are wrapped in a fine mesh of capillaries. These capillaries are very close together, and they have very thin walls for efficient gas exchange. This is a single alveolus. As I mentioned in the previous slide, the alveoli are very close together and they have thin walls for efficient gas exchange. This shows how each alveolus is surrounded with a capillary, and that capillary alveolus junction is endothelial tissue, and it's known as a basement membrane. As I mentioned, it's single-celled, and this is the wall through which diffusion of carbon dioxide and oxygen takes place. So the air is taken in, the carbon dioxide diffuses back into the alveolus, and the oxygen diffuses out into the capillary and is attached to the hemoglobin. It's passive. As you recall, diffusion is a passive movement of molecules from an area of greater concentration to an area of lower concentration. There's more carbon dioxide in the venous blood than there is in the inhaled air, so it goes from the blood into the air. There is more oxygen in the inhaled air than there is in the venous blood, and so the oxygen goes from the inhaled air into the blood, and that's how the gases are exchanged. Let's move to the mechanism of breathing and the muscles that are responsible for taking a breath. Ventilation is the movement of air in and out of the lungs. The primary muscles for ventilation are your diaphragm, which is a big flat horizontal muscle at the bottom of your thoracic cavity, and your external intercostal muscles. These are the muscles in between your ribs. You have what's known as accessory muscles. Some of them are used for inspiration, your sternocleidomastoid and your scalene muscles, which are up around the neck and the clavicular area. These muscles contract and try to pull air into the lungs. You have accessory muscles that are used during exhalation, which are your internal intercostals and your abdominal muscles, and those contract and try to push air out of the lungs. You use your accessory muscles during exercise or when you're having respiratory distress. The use of them causes retractions. You can visibly see these muscles trying to work to get air in and out of the lungs. The muscles of respiration are innervated by your intercostal and phrenic nerves, and your pleural cavity has negative pressure as opposed to the positive pressure, which is outside in the atmosphere. And if you recall from physics, air moves from an area of high pressure to an area of low pressure, according to Boyle's law, and that is the way that your body gets air in and out of your lungs. So if we look at inhalation or inspiration, what happens is the muscles contract and the diaphragm flattens. Lung expansion occurs because the pleural membranes adhere to the serous pleural fluid, and they expand this pleural space. The lungs expand. When that happens, alveolar pressure falls because remember the pressure inside the thoracic cavity is negative, and air enters the lungs because it's coming from an area of higher atmospheric pressure. If you want to inhale deeper, it requires a more forceful muscle contraction, and you all know what it feels like to take a deep breath. The rib cage muscles expand, the diaphragm flattens, and that's how inhalation or inspiration occurs. The term compliance refers to the ease of lung expansion or the elasticity of the lungs, and that's something that comes into play with certain different kinds of lung diseases that inhibit the elasticity of the lung tissue. Moving on to exhalation or expiration. As I mentioned before, this is a passive process normally. The lungs compress with the elastic recoil of the tissue and the air is forced out. You can have forced exhalation, which is an active process, and that happens when you ask people to breathe out as hard and fast as they can, let's say in a spirometry, which we'll talk about later when we talk about diagnostic tests, or when we ask them to blow up a balloon or blow into an incentive spirometer. Gas transport is the movement of oxygen and carbon dioxide in the body. 98% of the oxygen in our blood is bound to hemoglobin. The term PO2 stands for the partial pressure of oxygen in the blood, and likewise the term PCO2 stands for the partial pressure of carbon dioxide in the blood. So in the lungs, the PO2 is high in the inhaled air compared to the PO2 in the blood, so oxygen diffuses into the blood, binds with hemoglobin to form oxyhemoglobin. It travels through the blood into the tissues where the PO2 is relatively low, and so the oxygen is released from the hemoglobin and diffuses into the tissues. Most carbon dioxide, at least 70% of it, is carried as bicarbonate ions in the plasma. And if you recall from acid-base, bicarbonate ions are very important for acid-base balance. Chemical regulation of respiration determines the rate and the depth at which we breathe. So you have chemoreceptors in your carotid and aortic bodies that respond to the circulating level of oxygen in your blood. You also have breathing control centers in your pons and your medulla that respond to the pH of cerebrospinal fluid, and if you recall, the pH is influenced by the concentration of bicarbonate ions. So if you have a lot of carbon dioxide, the pH will be lower, and that is how those receptors pick up on changes in carbon dioxide. So these two centers of regulation balance each other. And when the carbon dioxide gets too high because of maybe a change in the efficiency of respiration or a disease process, your breathing rate and depth increases. And that's how these work. If you have someone who is chronically retaining CO2, their resting carbon dioxide level is high, then the receptors in the pons and the medulla tend to ignore that as a drive to breathe because it is high all the time. And so the oxygen sensors in your carotid and aortic bodies become more the drive to breathe. This occurs in people with chronic lung disease. We talked about it in acid-base balance. The respiratory regulation of carbon dioxide in the body fluids is a big part of acid-base balance. And there are primary respiratory acid-base imbalances, respiratory alkalosis and acidosis, and these are things that we talked about in a previous chapter in acid-base balance. The respiratory system also can compensate for metabolic imbalances, metabolic acidosis and alkalosis. So an example of this would be a metabolic acidosis like diabetic ketoacidosis, where you increase the the rate and depth of your respirations to blow off that extra CO2 and decrease the pH. This last slide portrays the age-related changes in the respiratory system. So some of the things that we talked about back in physical assessment and in pathophysiology that change as we get older are we have a decreased force of our cough, you get some air trapping, you have decreased gas exchange, and an increased level of respiratory infections. And if you look at this diagram, you'll see why these things happen. You get weaker, stiffer, atrophied muscles. You get a reduced elastic recoil of your lungs, so it's more difficult to exhale all the air in the air traps. Because of that decreased elastic recoil and the weaker muscles, the stiffer muscles, the force of your cough is decreased. Because you can't cough out as much of the trapped bacteria and other microorganisms, you get an increased risk of respiratory infections. If you go a little bit farther to the right, you will see that your cilia have a deterioration in their action and their ability to sweep those microorganisms out, again, increasing your risk of respiratory infection. You have a bit of a decreased cough reflex, again, diminishing your ability to get that trapped bacteria out, and so you have an increased risk of infection. And then finally, your immune system is reduced in its effectiveness. Remember those alveolar macrophages I talked about that engulf and phagocytize the bacteria? Those are less effective as we age, which increases the risk of respiratory infections. You have a reduced number of alveoli, and that coupled with the fact that there's some air trapping, you're not getting all the old stale air out, so you can't get the new highly oxygenated air in. That leads to decreased gas exchange. So all of these things are normal age-related changes. If you add a pathology or a disease state to any of these, then it can make things even worse. Thank you for listening to this PowerPoint on the anatomy and physiology of the respiratory system.